Rheumatoid arthritis is a long-term autoimmune disorder that primarily affects the joints. Most commonly, the wrist and hands joints are symmetrically involved on both sides of the body. Often, symptoms come on gradually over weeks to months. The goals of treatment are to reduce pain and inflammation and delay progression. Pain medications, steroids, and NSAIDs are frequently used to help with symptoms. However, disease-modifying antirheumatic drugs, DMARDs, may be used to try to slow the progression of disease. This presentation is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shams Faculty of Medicine. The narration was read by Microsoft David Voice. Let us start with the mechanism of action of various disease-modifying antirheumatic drugs. The pathogenesis starts with a self-antigen, since it is an autoimmune disease. After recognition of the antigen, the T lymphocyte starts the abnormal immune response. They send a signal to the B lymphocytes, which recruit plasma cells to synthesize immunoglobulins. One of these immunoglobulins, of the subtype M, is characteristic for the rheumatoid disease, so it is called rheumatoid factor. One type of the T cells, the T helper 1 cells, releases interferon, of the gamma subtype. This recruits the macrophages. Another type of the T cells, the T helper 17 cells, releases interleukin 17. This recruits the polymorphs and the monocytes. Now, how the pathology of the disease occurs. The immunoglobulin M binds the complement, and the classic complement cascade follows. The macrophages releases two important mediators that start tissue damage: tumor necrosis factor alpha, and interleukin 1. And the polymorphs, and the monocytes, release enzymes that destroy the joint cartilage and collagen, the collagenase, and the metalloproteinase. The most two important drugs, methotrexate and leflunomide, act on the lymphocytes, the T and the B lymphocyte. Tannercept, infliximab, and adalimumab target the tumor necrosis factor alpha. The anakinra targets the interleukin 1. Less commonly used drugs include abatacept, which targets the T lymphocytes, and the monoclonal antibody, rituximab, which targets the B lymphocytes. Now, let us classify the disease-modifying antirheumatic drugs. There are two major groups. The non-biologic group, which includes the conventional drugs. These tables shows all the members in this group. We will focus on the commonly used ones. The methotrexate, the leflunomide, and the sulfasalazine will be discussed in the next 3 slides. The hydroxychloroquine is to be discussed with the anti-malarial drugs. The second group, the biologic drugs, which are named so because they are biologic response modifiers. We are going to discuss the tannercept, a soluble tumor necrosis alpha receptor that attracts the tumor necrosis factor alpha instead of leaving it bind to the tissues. And the monoclonal antibodies, infliximab and adalimumab, which bind to and inactivate the tumor necrosis factor alpha. Then, we will discuss briefly the role of anakinra, which competes with interleukin-1 for its receptor, abdelbari, which prevents the activation of T lymphocytes, and rituximab, which destroys the B lymphocytes. The most important drug is the methotrexate, which is available in low dose, 2.5 mg tablets, for rheumatoid arthritis. It is used as one tablet every week. It is the mainstay of treatment. The action is delayed for up to 6 weeks. It slows the appearance of new erosions in the joints. It has 3 mechanisms of action. The first is the anti-inflammatory action, mediated by increasing the level of adenosine. Adenosine is metabolized by adenosine deaminase into inosine. Methotrexate inhibits the adenosine deaminase enzyme. The second mechanism is a direct immunosuppressive action, of unknown nature. The third mechanism occurs at higher doses, and is not related to its effect on rheumatoid arthritis. It useful for its anti-cancer action. Folic acid is activated by the enzyme dihydrofolate reductase, which converts the inactive dihydrofolate into the active tetrahydrofolate needed for cell division. This step is inhibited by methotrexate, that is, methotrexate is a folic acid antagonist, like the antibacterial trimethoprim, and the anti-malarial pyrimethamine. Now, what are the most common adverse effects of methotrexate, at the antirheumatic doses? It can induce mucositis, and it leads to nausea. With long-term use it may decrease the division of white blood cell precursors, leading to a granulocytosis. And it may lead to hepatic cirrhosis. And it may lead to respiratory infection, a pneumonia-like syndrome. The second drug, leflunomide, the substitute of methotrexate. This drug is also available orally. It has a long half-life, that exceeds 2 weeks, accordingly, a loading dose is needed to reach the steady-state concentration, CSS, more rapidly. Similar to methotrexate, it reduces inflammation and subsequently decreases pain, and slows the structural damage of the joints. The main mechanism of action is arresting lymphocytic division. Inside the cells, there is a substrate named dihydroorotate, which is converted into orotate by the enzyme dihydroorotate dehydrogenase. Leflunomide is a prodrug, When activated, it inhibits that enzyme, thus, preventing formation of orotate, which arrests cell division. The most common adverse effects are headache, diarrhea, and nausea. Other adverse effects include weight loss, flu-like syndrome, alopecia, and hypokalemia. The last one in this group is the sulfasalazine. It is a combination of a sulfonamide and a salicylate. When taken orally, it is not absorbed and reaches the colon, to be hydrolyzed by the colonic bacteria into 5-aminosalicylic acid and sulfapyridine. 5-aminosalicylic acid is an anti-inflammatory, and the sulfapyridine is an immunosuppressant. Because of its anti-inflammatory action, it is used in inflammatory bowel diseases, example ulcerative colitis, and Crohn's disease. And because of its immunosuppressive action, it is used in rheumatoid arthritis. Now, the biologic drugs. The first one is tannercept. It is prepared by recombinant DNA technology, where we join the extracellular part of the tumor necrosis factor alpha receptor with the human Fc segment of immunoglobulin G. This compound is soluble in the plasma. It attracts tumor necrosis factor alpha, instead of binding to its actual receptors. It used when the conventional drugs fail to retard the disease process, to improve the joint function, and to achieve remission. It is given as 2 subcutaneous injection every week. Usually, it is added to methotrexate. Since recurrence occurs within a month of its cessation, if it is used alone. The second group of biologics is the antibodies against tumor necrosis factor alpha. We have 2 types, the chimeric type, infliximab, and the humanized type, adalimumab. Infliximab has lower price. It is made by modification of the human immunoglobulin G, by adding a murine segment, to trap the tumor necrosis factor. Again, it is used in non-responders to conventional drugs and tannercept, together with methotrexate. However, it is not given subcutaneously as the tannercept, but is given by intravenous infusion. It is given more frequent initially, but the maintenance dose is every 2 months. Now, what are the adverse effects of drugs targeting tumor necrosis factor alpha? The first group of adverse effects are the infection. The most serious is tuberculosis. It is more with infliximab, and it occurs in the first few months after starting therapy. So, screening for tuberculosis is essential, before start, and periodically, for early detection. The second group is the effects that immediately follow the injection. There may be local redness and itching with tannercept. And there may be a systemic reaction, up to anaphylaxis with infliximab. The third group includes malignant transformation, especially lymphomas. The fourth group is CNS demyelination. They can exacerbate a dormant multiple sclerosis. The last group are abnormalities in the immune response. Antibodies may develop against the drug, which lead to loss of its efficacy. This is least with tannercept, but is more common with monoclonal antibodies. So, methotrexate is added to blunt this effect. If still, the patient response is inadequate, we may resort to anakinra, or abatacept. These two drugs should not be used with drugs that target tumor necrosis factor alpha. Anakinra blocks the interleukin-1 receptor, and abatacept blocks the receptor for CD28 on the T lymphocytes, thus preventing their activation. Anakinra is given as daily subcutaneous injection, and abatacept is given as a monthly 4 infusion. Finally, this is an algorithm for treatment.